doke. Let's talk about some stretching. All right. Recap. We went through the things that cause range of motion restrictions or mobility restrictions, flexibility restrictions, things like that, where that can come from. We talked about range of motion. The next tool in our toolkit is going to be stretching, right? How do we stretch for impaired mobility? So that's one distinction you'll make too is, you're not, sometimes you're stretching for performance, right? But most of the stretching that we're going to do is going to be associated with some degree of impairment or pathology. So let's go ahead and take a look here. Here's the definition of stretching. I'll let you read this, but, well, I'll read it. What the heck? It's a term used to describe a therapeutic maneuver designed to increase mobility of soft tissue. So we're talking specifically about soft tissue. And the way we're going to go about improving that mobility is by improving range of motion through the elongation or the lengthening of structures that have adaptively shortened and have become hypomobile over time, which just means that they contain less movement than what they should. So stretching exercises are going to contribute to fitness and conditioning programs, and they'll also reduce the risk of injury or re-injury, but they're going to have an important role in the rehab process in terms of not just reducing risk of injury or re-injuring or enhancing strength and conditioning, but restoring function. So a couple definitions you should know. Functional range of motion is just the presence of range of motion for a functional activity, right? As related to functional range of motion, like with the joint integrity or the flexibility, these things are necessary for unrestricted pain-free movements of the body for functional tasking. So this is just the range of motion needed for just performance of functional activities, right? So the difference between a goniometric or normalized range of motion measure would be, okay, shoulder flexion. Normalized shoulder flexion is 180 degrees. Well, functional range of motion is basically just the range of motion that's necessary for a functional activity. So if I have 135, 140 degrees of shoulder flexion, I can reach into a cabinet. That might be functional for me. So it's not necessarily normal goniometric motion. It's motion more attributed to necessity for functional activities. Functional mobility is the ability to actively perform movement as it relates to the function, right? So this would include like the soft tissue mobility and joint range of motion have to be at necessary levels of both muscle strength, endurance, and neuromuscular control to engage in more complex tasks of functional mobilities, right? So it's not just enough to have the available functional range of motion. I need to then now have all the other components or a grouping of other components that are necessary to complete a functional task, right? Having the range of motion or flexibility is one part of it, but do I have the strength? Do I have the endurance? Do I have the neuromuscular control? Do I have the balance and coordination, right? All those other tenets of function that start to come into play. So think of this as your Venn diagram, like we talked about. And soft tissue mobilities and for injury prevention, which we're getting as PTs and PTAs, we're involved in prevention more and more and more. Here's flexibility. This is just know the definition here and the difference between dynamic flexibility, which has to do with like sort of active range of motion, and passive flexibility, which is more dependent on passive movement. So this is like muscle extensibility, like the excursion of the muscle and connective tissue. Dynamic flexibility has more of a muscle contraction. So you're seeing that theme coming around and around. We should know what hypomobility is. It's just adaptive shortening of tissues, or by definition, it's just restricted motion, right? Usually caused by adaptive shortening of tissues. These are the factors that are associated with it. Obviously, immobilization, sedentary lifestyle, bad posture, or postural imbalances or muscle imbalances, weakness, trauma, some kind of congenital dysfunction, right? All those can contribute. Contracture is just an adaptive shortening of a muscular tendinous unit and the other soft tissues that cross and surround a joint that results in significant resistive to both passive or active stretching and limitations of range of motion. So there's different types of contractures. Definitely a contracture may compromise functional abilities, which is what we're concerned with. And they're always going to be named for identifying the action of the shortened muscle. So if you have a hip flexion contracture, it means that you have a contracture of the hip flexors of the iliopsoas, right? If you have an elbow flexion contracture, it means that you have a contracture of one of the flexors of the elbow, like brachialis or biceps brachii, right? So that's how we name them. Types of contracture are going to have a lot to do with the way that we, number one, identify them, but also how we treat them, right? So a myostatic or myogenic contracture is a shortened musculotendinous unit without really any specific muscle pathology, right? So this could go in the box of like, well, it's just been immobilized for a while, or the patient has a sedentary lifestyle, or their ergonomics were really faulty for a long period of time. And because there's no underlying pathology, you can usually resolve these in a relatively short period of time if you stretch appropriately. A pseudomyostatic contracture is secondary to some kind of hypertonicity issue, either spasticity or rigidity, associated usually with some kind of lesion of the central nervous system or damage to the central nervous system. Now you're thinking about stroke, CVA, spinal cord injury, traumatic brain injury, right? So obviously between these two, there's a lot more going on here, and we're going to be combating muscle spasm, guarding pain, and contracture resulting from hypertonic spasticity and rigidity as a result of some CNS impairment, right? So there's a lot more going on there. Other things ways we can define contractures. So that would be the sort of the causality of the contracture. The other part of it is going to be basically where the contracture actually is. So an arthrogenic, right, or a joint-centric contracture is going to be secondary to an intra-articular pathology. These are things like adhesions, synovial fluid, inside the joint itself, right, inside the joint capsule, joint effusion, irregularities in articular cartilage. So it's in the joint. It's sort of contained within the joint capsule. Periarticular contractures developing when the connective tissue structures that cross the joint or surround the joint start to lose their mobility. So they can attach to a joint or a joint capsule, and they restrict arthrokinematic movement, right? So you could have contracture of the muscular tendinous bodies. You could have potentially some kind of contracture that has to do with maybe ligamentous structure, right? Those could be contributing factors. And then you have a fibrous contractor and a irreversible contracture. So fibrous changes in the connective tissue of the muscle and periarticular structures can cause adherence and subsequent contractures. So that just means that if you have muscle changes, right, sometimes you'll have dense connective tissue being laid down at muscular junctions. Things like scar tissue, right, is going to change the fibrotic nature of the muscular tissue, and that's going to interfere with the opportunity or the ability for that muscle to stretch and reestablish or assume optimal tissue length. So that would be a fibrous contracture. Irreversible contractures are loss of soft tissue extensibility that occurs with high amounts of non-extensible fibrotic adhesion or scar tissue, right? So this is we have so much scar tissue now that has formed that we literally have a really, really difficult time being able to achieve any kind of stretch because it's now so completely bound. So it's sort of, there's a fibrous component to it, but it's an extent. It's reached the extent that now it's so prolific that it's almost like there's not much we can do. The other part of this is going to be heterotopic bone formation, which we'll show in just a second, but really not amenable to surgery after a while because it really comes from a long time of immobilization or trauma or inflammatory process. Or you can have what's called heterotopic bone formation, which is just abnormal bone growth in non-skeletal tissues. So you actually have bone osteocyte proliferation inside of the muscular or tendinous tissues or outside, or any other tissues really. It's bone being grown where it's not supposed to be, obviously. Stretching, again, general term to describe a therapeutic maneuver to increase the extensibility of a tissue. We can elongate previously shortened tissue, which is what we're going to be doing a lot. Other terminology would be selective stretching, right? So we are trying to impact the overall function of the patient by applying stretching techniques selectively to some muscles and joints, but allowing sort of limitations to develop in others, right? So it could be advantageous. We don't just need to stretch for stretching's sake. This goes even beyond like SCI stuff, right? So I'm not going to stretch things, excuse me, that don't need to be stretched, right? There needs to be a balance between stretching or strengthening, right? I should stretch the things that need to be stretched and strengthen the things that are overstretched, right, or weak. With a spinal cord injury, it may behoove the patient to actually have some limitations in the range of motion because it can help them perform functional activities. Overstretching and hypermobility is a stretch that goes well beyond the normal length of muscle range of motion, right? So well beyond functional and normative values, and the surrounding soft tissues. So sometimes that's necessary, right? Athletes need to be able to perform at a level of range of motion or mobility that is beyond the average person, right? So that excessive mobility, think like a gymnast, right, or a ballerina or a dancer. They're doing things that most of us cannot and probably should not do. On the other side of that too is if you have overstretching or hypermobility problems, stretching is not your answer, right? If you have a hypermobility issue, I'm not going to say, okay, let's just go ahead and stretch even more of the structures that are already overstretched, right? So you have to consider this in your intervention. So how do we affect the mobility of soft tissue? Well, we can manually or mechanically stretch it using external force. We can passively stretch it. The patient's not involved, right? I do all the stretching. They can assist in the stretching, and they could do self-stretching. Right? So these are all indications. Just know these: adhesions, contractures, scar tissue limitations, right? We can address those things with stretching exercises. Potential for structural deformity, just determined by limited range of motion. Weakness and adaptive shortening of opposing muscles, part of a total fitness program, and pre and post exercise. We're not going to stretch entities or body parts that have bony blocks, like joint structures that have bony blocks. I can't stretch a bony block, all right? I'm not going to stretch something that has a disunion or non-union fracture. Okay, that's a no-no. Acute inflammation or infection, for sure. For now, we don't want to encourage any greater proliferation of that infection or inflammatory process. Sharp or acute pain with elongation, right? If it may be uncomfortable, but we don't want it to be painful. Hematoma, tissue trauma, hypermobility, right? I'm not going to stretch into hypermobile structures. And hypomobility in terms of the fact that the functional needs are going to supersede the idea that I'm just trying to reach a range, right? If the shortened tissue is allowing for a functional skill, I want to keep that. Potential benefits here for outcomes of stretching and increased flexibility, general fitness, and prevention of exercise, or prevention of injury, reduce post-exercise soreness, and enhance performance. Okay, so these are some things we'll discuss. Please know these definitions, right? We discuss this a lot in class, so I'm just going to breeze through it. Elasticity is the ability of a soft tissue to return to its pre-stretch resting length right after a short duration stretch. Viscoelasticity is a time-dependent property of soft tissue that's going to initially resist deformation or the change in length of the tissue, but when the stretch is, at least initially, but when the stretch is sustained over a prolonged period of time, it will allow for a change in length, but still enables the tissue to go back to its previous length once the force was removed. So this is something that we'll use for non-contractile connective tissue. This is also why you'll start to see differences in the way that we're going to stretch contractile versus non-contractile tissue. Plasticity is the tendency of a soft tissue to assume a new and greater length after the stretch force is removed. So we call that the plastic range. We're trying to stretch a tight muscle, combat adaptive shortening by having that muscle try and assume a new and greater length, right, to improve function. Remodeling is the gradual rearrangement of fibers with low magnitude loads over a long time in the elastic range, right? So after a while, if you hold things, you can end up with hold a stretch, you can end up with remodeling of that tissue or just a rearrangement of the fibers with low magnitude loads. And failure is something you never want to do, which is rupture of the tissue integrity. That's bad for business. So here's a great chart that you should commit to memory and probably hold in your little clinical toolkit. There's the components of the stretch strain curve, So this is a hypothetical ACL ligament here. I have a toe region, which is essentially taking the slack out of that tissue, right? In this case, the ligament. Then I have an elastic region, right? that's going to, as the stress increases, going to um, achieve taking that particular structure, in this case the ACL, to its maximum physiological length, right, or range, which is basically just the ligament doesn't have a lot of motion compared to like a contractile tissue, but it has motion built in. We take it to the end of that range, that's the elastic region between the toe region and the end of the physiological range. Once we move into beyond the elastic region, we now move into the plastic region. Remember the idea of plasticity, right? Tendency of these tissues to assume new and greater length over time, right? So if I'm trying to achieve greater length in the plastic region of this ACL ligament because it's too tight, right, which is restricting movement, I need to get it to this degree of the plastic region and hold it within that area to incur a certain level of microfailure, just microfailure. It's the microfailure that's going to contribute to the permanent deformation, which sounds bad, but as long as you're here, it's actually a good thing. Permanent deformation of that particular tissue, this ligament, right, which will help to lengthen the ligament over time. And so we're going to get a certain amount of remodeling that's going to happen. We're going to have a certain amount of viscoelastic principles where if we sustain the force over a period of time, we can change the length in that force. But if we don't take it to the plastic region and incur some small micro failure, we need to incur this so that when it sort of remodels itself, it remodels itself in the length of, or within the shape with the level of movement or mobility, or newly found mobility that we want to maintain. And you're never going to push anything. This would be an injury, right? Complete rupture. You don't want to push things so far that you move into macro trauma or macro failure and then ultimately complete failure, which would be tearing the ACL in that example. So here's another picture, serve you in good stead. Here's our example of some of the elasticity principles, right? If I go back, this rubber band is elastic. I can bend it, I can stretch it, it resumes its normal shape. If I hold it bent for too long, eventually the rubber band will start to lose its original shape because it's now more lengthened than it was originally. But if I overdo it and introduce too much strain on the stress strain curve, I can result in rupture, which is not what we want. So here are the mechanical properties of your contractile tissue. Relates to the actin and myosin elements. We don't have to go back to that. Stretching can increase the length-tension relationship and allow for normal resting length, right? Elasticity. Prolonged stretching is a byproduct of plasticity, which can lead to more permanent length changes. That's kind of the whole reason we stretch to begin with. If these units are all allowed to rest in a shortened position for a long period of time, that's when you end up with these adaptive changes. So it works both ways, right? I can either gain or lose range of motion depending on what I'm asking the muscle to do or not do. Mobilization is the enemy, right? Results in all these bad things you can read all through here. Atrophy, decay of the contractile protein, shortening, adaptive shortening positions. So you have to be aware of this when somebody has an injury and they've been immobilized. These are the things you're going to start to combat against almost immediately, but you have to be able to stage it in a certain way. Immobilization in a shortened period position is going to have decreased the length tension relationship, which is sometimes necessary. Mobilization in a lengthened period or position or a gradually lengthened position can increase the number of sarcomeres in series and actually help overlap. So they do serial casting, right? They'll cast you in one range of motion, then they'll increase the range of motion, cast you again, or like an immobilizer brace where you're restricted to just 90 degrees and then it's 110 degrees, 120 degrees, right, over time. So these are the ways we can do manual or mechanical passive or assistive stretching. That's a pretty intense assistive stretch. Probably won't do that with your patients. Self-stretching, PNF techniques, inhibition techniques we did in lab, joint mobilization, manipulation. For us, PTAs, it's mobilization. Soft tissue mobilization, you guys have learned, right? Make sure that all the structures are aligned. Make sure that you're stabilizing properly. Make sure that you are aware of the intensity of the stretch. Pretty much the rule of thumb for this is low load, long intensity, long duration, low intensity, long duration, or low load, long duration stretch is going to be the best way to stretch your patients. Typically, now this could vary depending on pathology, but that's the sort of the golden standard. Duration stretch again is 30 seconds. Typically is found to be, based on review of literature, to be the sort of optimal duration, but again, it does depend on the pathology. They use static stretching, right? This is just a stretch and hold technique. Probably not the best thing to use prior to some kind of explosive output. Dynamic stretches, there's no bounces or jerky. That would be more ballistic stretching, where you have like shaking motions, jerky motions. Dynamic stretches are slow, controlled movements, but there's no sort of static hold at the end. You just elicit the movement, and then you come back out of the movement with fairly slow and controlled sort of cadence, tempo. So there's like static stretching, low intensity, long duration hold for 30 seconds. Dynamic stretch, the end range hold is brief, and we use this sort of as a warm-up period, but there's really no long hold at either end. You're just doing it with intention, with purpose. PNF stretching is based around the idea of musculoskeletal contraction can lead to musculoskeletal relaxation. Not really, not going to be super effective necessarily for paralysis or spasticity-based conditions, right? And then your ballistic stretching, it's a form of dynamic stretching, but more or less, but it's a quick jerky movement, right? That's going to be mostly to prep you for some kind of movement. So hold relax is a PNF stretching technique where you're going to take the limb to a position of end range, the end range limiting muscle. Then you're going to have the patient engage in isometric contraction of the range limiting muscle. And then as soon as they contract, okay, push against me, hold it, 1, 2, 3, 4, like 10 seconds, right? Then the therapist or whoever is going to passively move that limb into the newly gained range of motion within the agonist pattern, okay? Hold relax is basically the same thing, except after the isometric contraction, I'm going to have the patient engage in an immediate concentric contraction of the muscle opposite of the tight muscle, okay? So what they'll do, like for example, if you're stretching, like you're going to then you'll hold the limb at the end of the new range for several seconds and repeat that over again, right? So they're going to have a contraction of the tight muscle. They'll go ahead and they'll go through the hold relax. They're stretching out, let's just say the hamstring. They'll have an isometric contraction of the hamstring, followed by a concentric contraction of the quad immediately following, right? In this case, the antagonist. So these help a lot. Those are some just useful PNF patterns you can use. Examination, right? We have to evaluate, prep them for stretching. We have to give them procedures and apply the manual stretching in the right way. And then what do we do afterwards? These are adjuncts to stretching. All those are things that you should really take to heart. And while the PowerPoint stuff is good, there is no substitute for just getting your hands on as many people as you can find for stretching and range of motion work, and what will also be peripheral joint mobs. So that'll wrap it up. I think we did some key highlights here. Should have enough information to do well on your quiz and just jog your memory if you didn't catch something during lecture. So good on that one. And we'll just do one quickie to finish up with peripheral joint mobs.